and welcome to our webinar where we're presenting the findings of phase 2 of our study, evaluating the implementation of digital social care records, or DiSCRE for short. My name's Joanne Westwood. I'm a Professor of Social Work Education at the University of Central Lancashire and one of the co-lead investigators for the study. My colleagues will introduce themselves as we go through the presentation. So as Jo has said, the webinar is being recorded. So if you don't wish your voice to be recorded and you have any questions or comments, please use the chat function. When we share the recording of the webinar, we won't be including the Q&A session. So our study is funded by the NIHR, who we want to acknowledge here, along with our colleague Tamsin Walker, who's supporting the co-production elements of our study, and Jo Wood, who you've met, who's our administrator. We'd really like to thank the research development networks across England we've been working with, and the digital social care records suppliers who've given up their time to participate in our study. We've got a great big thanks for our Evaluation Advisory Network for their contributions to the design and development of the study and for undertaking some of the peer research interviews. And we'd really like to say a big thank you to all the people who participated in our study, who draw on care services and their families and staff in the provider organisations for their contributions in phase 2. So without further ado, I'll hand you over to my colleague, Juliet.
Hi everyone, so I'm Juliet Malley. I'm co-director of SOCRATES and also co-lead for this project. So before we get to the interesting bit, I'm just going to give you a bit of a brief overview of the plans that we have for this project and what we've done. So the aim of the project was to generate evidence that helps local areas and organisations to implement digital social care records within adult social care providers in a way that delivers the greatest benefit for the most people. So we're working with 4 sites across England. You can see them marked on the map there, so they're sort of spread across the country. We're working with 30 providers across those sites. So in the first stage, at least, adopters and non-adopters. In the second stage, we've just been working with adopters of records. The sites, the providers included care homes and home care organisations. And in the second stage, we worked with just 10 of those, all adopters, as I said, it was selected for phase 2. So as Joanne mentioned, we've worked a lot with our Evaluation Advisory Network, our EN, to co-produce the study. This comprises members of the public who had an interest in digital social care records and also people working in provider organisations and key stakeholders. And we've had some really valuable meetings and discussions with them about the findings. And as I've already mentioned, they've helped us with gathering some of the data too. So as I said, there's several phases for the work. We've completed phase 1, and there was a previous presentation about that, which you can find online, and we can direct you to that if you're interested. Today, we're going to be concentrating on phase 2, which involved interviews with 30 care staff, so people working within the provider organisations, delivering care to people who are drawing on those services. And then we also interviewed 20 people who were drawing on care or their relatives. So that was actually broken down as 11 of kind of people drawing on care and 9 relatives. Now, because this was a rapid evaluation, we've been using rapid methods for our analysis. And also, as part of that, making sure that, we're feeding back our findings as early and as frequently as possible, just to make sure that the work is useful and relevant to people. And so today's webinar is really part of that, trying to make sure we're feedback findings early and make it as relevant as possible. So I will pass on now to Nicola, who will take you through the interesting bits.
Thank you, Juliet. So yeah, I'm Nicola Farrelly. I'm one of the researchers working on this project, and I'm based at the University of Central Lancashire. So to start, I'm going to share what we heard from care workers and clients or their relatives about their experiences of the different features of digital care records. First, in terms of what works well, and then what needs to be worked on or improved. Okay, so I will start with icons. Icons were generally considered to be a positive feature of digital records. Icons such as food, drink, shower symbols, and so on for each area of care provision that needed to be recorded. Care workers talked about icons being useful for staff with dyslexia or for those who prefer to be guided by images rather than by text. And we heard that icons could really help workers to navigate the digital interface more easily because icons clearly signposted them to the various areas of the record. And images were also more memorable than text. So digital records that showed a birthday cake on someone's record, for example, would remind care workers about a client's birthday throughout the day. Icons also help to remind care workers of required tasks, and we heard that automatic alerting on the digital record meant that tasks couldn't be missed, and that prompts to record tasks meant that they were reminded to do so at the right time. Icons were also a useful function for some relatives who told us that once they got the hang of how the record looks, the icons could help them to navigate to the area that they wanted to access more easily. Okay, the next one is the patient and the family portal. Okay, and we heard that digital records were often used by relatives to check care worker rotas to reassure them about who will be coming into their homes to provide the care. And other relatives told us that they used the portal to make sure that the recording was accurate. However, the portal seemed to be most valuable for relatives who didn't live with the person who was being cared for, to reassure them that care was being provided and which they could see in real time. So, for example, as this relative explained, when I'm at work or my brother is at college, we can check the notes online just to see how things are going at home, just to make sure that obviously mum's been receiving all the care that she needs to. We also heard that this feature was useful for care workers who could leave messages for relatives rather than calling them directly and displaying their phone number, which they might not want to do. Including images. So we heard examples of how using images in care records was useful. So, for example, care workers told us that they could use the function to look back at photographs of activities or outings which clients had been involved with or done, which created talking points and helped to enhance the care relationship, looking back and reflecting and having something to talk about. Including profile images of both the care workers and the clients meant that clients would know the identity of the care worker who was due to visit their home, and also care workers would know the identity of the client as well. Okay. The speech to text function. This is something that can translate the spoken word to written text, but this was really rarely mentioned as a function that was used by care workers. However, we did hear of one example of workers using this function to record their notes in a home for people with dementia, to enable them to record their notes quickly and also as the care was provided. Okay. So we also heard about the specific features of digital records that needed more work. Okay, so icons. We heard that using icons can limit the quality of care recording and also limit the detail that might otherwise have been recorded in paper systems. So, for example, around the intake of fluids and food, some systems only allow recording that this was given and not, for example, how much was consumed by the client. We also heard that emojis could be selected to record a client's emotional state, and this could potentially create superficial and also inaccurate records. So, for example, where there was a choice of only 4 emotions, which workers had to select from. But that could be counterbalanced within systems where there was a better balance between icons and also open text, as long as the software allows for that open narrative for workers to record as well. Okay, the patient and the family portal. So we heard that this wasn't really being used to its full capacity in many cases. And for relatives in home care settings, this function was more often used to view staff rotas, as I mentioned, although it also seemed to be used more by relatives who lived away from the person who was being cared for. But we also heard that clients and their relatives may need more tailored information and also training about how patient and family portals work, and how they can use it fully, and so that their experience is a really positive one. Okay. So including images. So although we heard that this function was being used and was a really useful function for recording activities, creating opportunities to enhance care relationships, by sharing and recalling memories of events. We also heard that there were difficulties with some software around uploading images from the phone camera onto individual clients' care records. All the images could only be uploaded once, so staff were having to take several photographs of the same image or spend time transferring images via Bluetooth, for example, rather than recording directly into the care record. Okay, and then speech to text, yeah, as I mentioned, the speech to text function wasn't really widely being used from what we heard, partly because of the inaccuracies in the way that software transcribes voice files to text, but also because care workers talked about feeling that it was insensitive to say the information that they were recording about a client out loud in front of them. As this care worker explains, they say they don't want to be walking around talking because it's not professional to be talking about a resident in front of a resident, and there's never really a time when you're on your own. But there were also issues with the software not being able to understand different accents or non-native speakers as well as it might do. So the notes weren't always accurate. And so it may be that perhaps a translation feature might be more helpful to include, whereby non-native speakers could record in their preferred language, and then for that to be translated into English for the record. Okay, and then finally, we heard examples of useful features that are no longer available. So, for example, one client from a care home described the usefulness of having a pain check function on the digital record, particularly for non-verbal clients, as they explain in this extract in green. They said, she's not verbal, but we were noticing that she seemed agitated with her leg. There used to be a pain thing on Nourish. You'd rate the pain check, and the staff realised that's not on Nourish anymore. They could look and say, okay, this person has read their pain and we'll keep an eye on them throughout the day till the night staff come in. So that was just a useful feature, one example that's no longer available that could be valuable to reinstate. Okay, and then I'm going to pass on to Nicole.
Thank you very much, Nicola. Yeah, so I'm Nicole Stalz, a research fellow at King's College London, and I will be talking about this sort of the digital technology with digital systems and experiences that care workers and residents in care homes or clients, people drawing on care or their relatives have made and what told us about in our study. And obviously, care documentation is nothing wrong, but sort of the impact that had on how care processes are now recorded in those days. And Nicola's already said, you know, there's a bit of a drive towards more accuracy and more transparency. That is also the case from policymakers and commissioners who sort of expect that, how it is recorded by the Care Quality Commission. And we found that that is also something that specifically relatives are asking for, where they have an interest in looking into the recordings. But it also feels that it sort of puts a bit of a strain on care workers to do the care recording in the moment. So as we've heard, they carry devices with them in care homes. They also have the ability to connect into a system when they provide home care. And it feels that they have a feeling that they really need to record in the moment, sort of live almost. And sometimes that puts a specific problem if there's an emergency situation, sort of to make the decision, what do I do first? Do I record first, or do I ask for help first? And we're not going to say that this is a reoccurring situation, but we have been told by one of the residents who've been taking part that they had the feeling that in a situation where they had a fall, it was more important to take a recording of the fall rather than ask for help and being looked after in that moment. It's obviously something that needs to be looked into, whether that's the case. But it's just sort of that situation that we often also hear about if there are accidents on the street and people get out their phone and take videos. And we're wondering whether that sort of whether that's an effect that could also take place here. So it's definitely something that puts stress potentially on care workers. The other side on that is also, you know, where, and that is the quote that I've put here, where some care workers said, well, it's a blessing and a curse. And that is using technology around people who are maybe less accepting of technologies, of using mobile phones, especially if it is home care where they use their own mobiles. And people are saying, well, it feels rude. I've been told, you know, put your phone down. This is really rude. What are you doing? And where clients just don't really understand what is going on, that this is not to check out any private messages, that this is recording of the care that has just been provided. So we've been told by care workers that they either try to do the documentation away from the client, maybe when they boil a kettle, or that it happens in their own time, basically after leaving someone's home. So they make the recordings and the care documentation on the doorstep, or when they're in the car. And that in some cases, that means the care documentation is not done as part of the care visit, but is actually done afterwards, potentially in their own time, or where clients have the feeling, you know, this is not done as part of the process. Where are they? So the visit has actually not taken the time that they paid for or someone else paid for. So there's a bit of a tension ongoing there. The other one is the ability to add and change records. And this is slightly now different to what we heard in phase 1, where managers told us that records could actually not be edited. It seemed things have moved on. We heard from care workers who sort of echoed the situation, that they were not able to edit records some time ago, but that has now been enabled. In some cases, it seems they can change the record directly as it is visible to everyone. In other cases, or with other suppliers, it is so that you can add an additional note, but connect it to the note or to the record that was taken earlier. This seems to be actually really important, as we were told that it is not too uncommon that the system is down, that people cannot access the system. That's either if in a care home where the system is completely down, no one can use it, or where people are out and about in the community and there's no connectivity to the internet. So they need to then have a sort of plan B or contingency plan. It seems in care homes, this is usually going back to paper records. Those providing home care told us that they often take notes then in a notepad software or the other software to then add that or copy and paste it into the records. But that can leave, if you have the timestamps on it, some really weird situations where maybe a recording is done later than something else. So we heard about a situation where someone recorded, you know, having provided a cup of tea later, basically after a person had already died. So obviously that was not the case in reality, but that is what the recording showed. So we think it is really important that care workers put in, you know, this is in addition, or this has been recorded later. So the timestamps, you know, are not just to follow. You made to make sure that everyone can see that there's a difference in how it actually happened in reality. We heard from some home care workers who told us that the system updates during the day, and they thought that's not really helpful because that would also lock them out from the system and being able to record in time. But it brings us back to sort of the expectations of relatives who said, well, you know, I know that the visit has taken place. I log in and I want to see what has taken place. And actually the records are only updated an hour later. And I don't know whether that's the system or whether it is the care worker making that note later. So I think there's a need, as Nicola said, for relatives or people receiving care to sort of have the right information, how records are updated and how quickly the system updates and syncs with their ability to log into the family portal. So the use of own private mobile phones, which seems to be the case almost everywhere in home care, at least with the providers that we talk to. Security does not seem to be such a problem, as often, obviously, there's quite a security around logging into phones, but also suppliers have put extra barriers into logging into the system or into private clients' records. So that's not so much an issue, and we didn't hear from anyone feeling that there is a huge issue around that. But if you use your different phones, we heard that the interfaces are different between Android phones and iPhones. And again, that could lead to issues with syncing, with records coming through later than they were recorded. And also just they look different. So the records themselves are probably not different. No one had made any experiences around that, but they just looked different. And if you're not used to someone's iPhone or an Android, you just think what is going on, and it can be a bit confusing. And then it's also the access to the system obviously depends on provider networks. So whilst we heard that someone had absolutely no problems with connectivity, being in rural areas, other people said, yes, my network often lets me down and I need to swap networks and it takes some time. And again, then there are issues with recording and uploading and syncing of the process. As in phase 1, we heard there's still problems with interoperability and working with other professional agencies. And we heard that there's maybe some issues around consent and access rights. So relatives or clients not really knowing who has access rights. So again, maybe being more upfront about that. And I think that's something that Martha will talk about in her section. But she just heard that was something that was really important to many people. And again, we felt, there are chances around that to make that better, bringing in more professionals. And it was something that a lot of relatives asked for, where they thought, that it's the system that is made up of so many multiple records and they just don't talk to each other. This needs to be overcome if we give consent, obviously. So there are quite a few tensions around the documentation and care delivery. It's sort of there's heightened expectations around flexibility as well. People feeling, care provision should not be black and white, but people telling us that they felt the new way of recording in a digital system has actually made it more rigid than care recording used to be the case, at least in their experience, compared with paper recording. And they felt that had an impact on how care was provided. That they felt, there is a list of tasks, and they go through this task, and that there is no sort of flexibility around making changes to care plans on the day, even though it might be sometimes needed if there's an emergency, but also maybe wanted by a client. And they felt that there is sort of no one size fits all. But they had a feeling the digital recording could lead into that way, and they felt that would be something that needs to be looked into. And I'm handing over to Martha, please. Thank you.
Yes, right. So I'm Martha. I'm a research fellow at LSE, so the London School of Economics. And I'm going to be talking about 2 themes today that came out in phase 2. So the first one is equality, diversity and inclusion, or EDI. So first, I'll talk about this in terms of clients and relatives. So this was a recurring theme in this phase. So older clients and relatives frequently told us that they would struggle to access the DSCR. The inaccessibility of digital service devices was a big reason for this, such as small text on phones and relatives not owning computers. Others were unsure whether they would be able to navigate an online portal that involved lots of clicking around and typing. And as alternatives, they suggested read aloud and large text options to help with this. This indicates that training would be important for the introduction of a family and patient portal or similar access for clients and their families. Clients did often think that access to the DSCR would be beneficial, however. Some thought that if relatives had a family and patient portal, they could easily be made aware of any problems. For example, if their loved one hadn't slept all night. Younger clients, in particular, were enthusiastic when the patient and family portal was explained in the interview. They thought that it would help stop their families worrying about them. As you can see in the pink speech bubble, one client in a respite service said, I would do the patient and family portal. The parents can, if they want to, see the negative stuff. Because I feel if mum saw that, she would then ring me and be like, I've seen that you've had A, B, and C today. Are you okay? So another said that he would like the option to personalise his portal, for example, renaming it Jake's portal. All of the names are pseudonyms just to keep confidentiality. This then raises the question of a client's right to view their DSCR. Despite liking the idea of access, clients frequently thought that staff wouldn't allow them to view their DSCR because the information is private or for care staff only. As you can see in the green speech bubble, one care home resident wondered whether such a request would actually be viewed negatively. So she said, I hope they'd think I was, okay, not making waves or being awkward, Probably they would let me see it if I was, interested to know. This is not necessarily a criticism of care providers. Clients and relatives were generally really happy with how information was communicated, whether that was in the form of staff going through printed care plans with residents every few months, relatives receiving regular email updates, or regular meetings for relatives and clients with staff each month. And a lot of clients in one care home talked about using the nursing station, and they knew that that was where they could get all of their information. However, they were often unaware of the DSCR and had not been told what it was. Those who did know about it had usually taken it upon themselves to ask at some point. As well as feeling unsure about whether they could view their records, clients, and especially older people, were rarely informed of who was able to access their records and what information was stored on the DSCR. Many older clients and relatives thought that their data was boring and not of interest to potential hackers, while others thought that the DSCR didn't even include their personal data. I mean, one person said, it's not like it's going to have my address in it, is it? So their trust in the staff delivering their care often led residents to trust the DSCR without feeling the need to ask much about it. And this came out really strongly in the interviews. However, as the DSCR is often left unexplained, it's difficult for clients and relatives to fully understand any potential data security risks. This then becomes a wider ethical issue about what clients and relatives should have the right to know and access, which I think Nicole and Nicola have alluded to. It's food for thought, but the key takeaway we think from our research is that people appreciate having a choice of engaging with the DSCR or another version of their records. So in terms of care staff, EDI issues that related, to staff, I think Nicola's already talked about this, but it mainly centred around challenges for non-native English speakers. So yes, as Nicola said, I don't want to kind of repeat it, but the speech to text was actually not helpful for non-native English speakers, which is contrary to what some of the managers told us and they thought was the case in phase 1. So as you can see in this image, one care worker actually showed how the speech to text can transcribe incorrectly during her interview. So again, this is another pseudonym, but she says, hello, Adir, today me coming no. And then I said, what she said and what was being typed is completely different. Oh, actually, that's very different. And this is what the DSCR had written. Hello, Saturday, me coming over. So as you can see, it's extremely different to what she tried to say. So non-native English speakers often thought that a translation feature would be more helpful, again, as Nicola has said, where they could speak or type into the device in one language and it would be automatically translated into English. They also recommended a less technical alternative, which would be just to have the DSCR available in other languages. So even if the data was being entered in English, the record template could still be navigated in other languages. And I think it's important to note here as well that making records available in other languages could also make them more accessible for people drawing on care who are also non-native English speakers, particularly in home care contexts, for example. One care provider working with staff and clients from multilingual backgrounds thought that setting a minimum reading and writing level in English at the interview stage had aided their DSCR implementation process, because the care workers who they had hired were able to read the digital record when it was introduced. This raises the question as to whether DSCR suppliers should make it clear what the minimum reading age is needed to use their product. Yes, this would help care providers purchase DSCRs that are suitable for their staff and clients. So how do we make implementation work? And what have been the most important factors for successful implementation? So I'll split this up again into suppliers, managers, and then people drawing on care and care workers. So in terms of DSCR suppliers, the offline working feature was praised by many as a handy and frequently needed feature, as I think Nicole pointed out. This is where the DSCR can function offline for a period of time if the Wi-Fi cuts out or the data cuts out, and then upload the data once it's back online. Where offline functionality was limited or unavailable, care workers often struggled to update records in a timely manner, and in some cases, home care staff were stuck trying to update the DSCR on clients' doorstep once in the rain, because if they moved location or lost internet, the system would log it as a false checkout. So that was in home care. DSCR suppliers may want to include an offline working feature, and care providers may want to look for this feature when purchasing a DSCR. DSCRs that were seen as flexible to the diverse needs of the sector were also held in much higher regard by care staff. When asked what she would like to see in the future, one staff member told us, "I think flexibility should not be having us as a group and us as a stage, but realising that we're individual companies, we do things differently, so the system should actually tailor to each specific company." This is linked to the fact that some care staff who had experienced challenges were highly critical of DSCR suppliers who they felt refused to make changes based on provider feedback or provide ongoing support. Suppliers that were viewed as engaging with the sector and listening to concerns were regarded much more positively. In terms of care provider managers, care workers often reported that a key success driver was when management were receptive to staff feedback and they felt supported by an open and collaborative work culture. Care providers where management were committed digital leaders were better equipped and more motivated to encourage any apprehensive staff. One senior care worker spoke of the commitment to ongoing support for staff who were still struggling, as you can see in the speech bubble. "Every time we're in handover, I'm like, if you're still having problems, please just, we'll come. Don't feel embarrassed and feel like you can't record something properly." Last but definitely not least, we found that high quality training was one of the most important keys to success. This involved training delivered in different formats so that it catered to everybody. For example, having both in-person and online training, and embedding training in induction processes moving forward. Using dummy clients before going live also helped care workers learn the DSCR without worrying about making mistakes. So in terms of care workers, people often told us that receiving peer support from their colleagues, sometimes in the form of buddying up on home care visits, was really beneficial. However, as a caveat, we did also hear that buddying up and peer learning could lead to sharing bad practice if there were other issues with the DSCR that needs addressing separately. Some care providers had also approached tech-savvy care workers to become DSCR champions, which they said supported implementation. Finally, as I've mentioned, our findings strongly reflect that clients and their relatives would like to have the choice to engage with an accessible version of their DSCR, and for care providers to inform them about what information it holds. This would ensure that they are more informed about what happens to their personal data and who can access it, along with all the potential risks and benefits that this entails. Training for clients and their relatives would help to dissipate any concerns about care workers using their phones, which was sort of mentioned as an issue in some places. And it would also support clients and relatives to meaningfully interact with their DSCR, as one staff member highlighted in her hopes for the future, which I think is an eloquent place to end. I would like to see training for everyone to use the systems that also include service users, so that they can have a better understanding of what the carers are doing, and also so that it's accessible for them, so they can actually read their reports, not just give them passwords and login details, but we can sit down with them and support them to actually access their records however and whenever they want to. And that's it from me, so I'll pass you back to Joanne.
Thank you very much, Martha, and Juliet and Nicola and Nicole for that. And just a reminder that we've talked about the different features of digital care records and some of the constraints in the context of care relationships, equality, diversity and inclusion, and how we can make implementation work better.